Welcome to the Deep Dive, your shortcut to expertise. We take dense, critical professional literature and translate it into knowledge you can actually use, knowledge that sticks. Today, we're tackling a really complex one, the renal system. We're aiming for, well, complete mastery of perioperative renal function. Our sources are specifically geared towards advanced nurse anesthesia practice. So this isn't just a basic review. Our mission here is to get to that elite professional level of understanding. We need to really internalize the structure, the physiology, how things go wrong with AKI and CKD, and maybe most importantly, the anesthetic management needed to protect these vital organs during surgery.
And it absolutely deserves that level of focus. The kidneys, they're the ultimate regulators, aren't they? Keeping everything in balance, their main job. Getting rid of waste products from metabolism while carefully controlling everything in body fluids, electrolytes, water, acids, bases. It's constant balancing act. And it does all this through basically four main things, right? Filtration, reabsorption, secretion, and then finally excretion. To manage anesthesia well, especially around the kidneys, you've got to know how surgery, our drugs, how all that stress impacts these delicate processes.
Definitely. So let's start with the foundation, the actual blueprint of the kidney. We're talking about these paired bean-shaped organs, reddish-brown, tucked away retroperitoneally. So behind the main abdominal cavity, they sit roughly from T12 down to L3. And something we often forget, the right one's always a bit lower.
Yeah, that's just the liver pushing it down. Hepatic displacement, they call it.
Right. Simple anatomy.
And, for organs that are only about 0.5% of our total body weight, 125 to 170 grams in men, a bit less in women, their function is just huge compared to their size.
About 11 and a quarter centimeters long.
Mm-hmm. And when you look at the kidney itself, you see that outer layer, the cortex, which is really packed with blood vessels, and then the inner part, the medulla, looks paler.
And that medulla has this really neat structure. It's got these triangular segments, 8 to 18 of them, renal pyramids.
Mm-hmm.
The wide base faces outwards towards the cortex, and the pointy tips, the papillae, they point inwards. They actually drip urine into these little funnels, the calyces.
Which all merge together, into the main collecting area, the renal pelvis.
And then that narrows down into the ureter, which leaves the kidney at the hilus, that kind of concave spot where everything goes in and out, artery, vein, nerves, lymphatics, ureter.
But like you said, the real action, the genius of it, is microscopic. It's the nephron. We have something like, 1.25 million of these tiny functional units in each kidney. It's staggering.
Wow.
And tracing the path fluid takes through one is key. It goes glomerulus first, that capillary tuft, then into the Bowman's capsules surrounding it. Then the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and finally it drains into the collecting duct.
And you mentioned there are millions of these, but there's actually a really important distinction based on where they sit, right?
Exactly. Most of them are what we call cortical nephrons. They're mainly up in the cortex, maybe dip a little into the medulla.
Yeah.
But then you have the juxtamedullary nephrons, maybe a fifth up to a third of the total.
Okay.
These guys are positioned deep, right near the border of the cortex and medulla. And crucially, their loops of Henle go way down into the inner medulla.
And that location difference is key for function.
Absolutely vital. These deep juxtamedullary nephrons, they are the primary players in the kidney's ability to concentrate urine. Their structure, dipping way down, is what allows the kidney to set up those huge osmotic gradients needed to pull water back.
Which brings us nicely to the blood supply. It's massive. That tells you a lot about the kidney's job right there. It gets 20–25% of cardiac output. That's huge. 1,100 to 1,200 milliliters every minute.
Yeah, for organs that are, again, only 0.5% of body weight, it screams regulation and fluid processing, not just metabolism.
So how does that flow path work to actually enable filtration?
Well, the main renal artery comes in and branches down, down, down.
Mm.
Eventually, you get to the interlobular arteries, and off those come the afferent arterioles, afferent meaning arriving. Each afferent arteriole feeds into a glomerulus, and that's just a specialized little knot of capillaries designed for high pressure to push fluid out.
Okay, and here's the clever part, the plumbing trick. Blood doesn't leave through a normal vein, does it?
No, it leaves through another arteriole, the efferent arteriole,
Yeah.
efferent for exiting. And critically, it's slightly smaller in diameter than the afferent one.
Ah, the bottleneck.
Precisely. That size difference creates resistance, keeps the pressure inside the glomerulus high that's essential for filtration.
And after the efferent arteriole.
Then the blood pressure drops way down, and the efferent arteriole breaks up into a second capillary network. This is either the peritubular capillary bed, which winds all around the tubules up in the cortex,
Okay.
or it forms the vasa recta. These are long, hairpin loops of capillaries that follow the loops of Henle deep down into the medulla.
So two distinct capillary beds in series. High pressure first for filtering, low pressure second for reabsorption and secretion.
You got it. And the distribution of that huge blood flow is also really important clinically. The cortex, where the glomeruli are, gets flooded with blood, like 3 to 5 milliliter per gram per minute. Super high perfusion.
But the medulla?
The inner medulla gets surprisingly little flow, only about 0.3 to 0.6 millilog min. And that's delivered by the vasa recta, which only carries maybe 1 to 2% of the total renal blood flow, RBF.
Okay, hold on. If the medulla, especially the inner part, is so crucial for concentrating urine with those juxtamedullary nephrons, why does it get such little blood flow? Seems counterintuitive. Why starve it?
It's not starving it. The low flow is essential for its function. Think about it. The whole point of the medulla is to be incredibly salty, hyperosmotic, packed with sodium chloride and urea.
Right, to draw water out later.
Exactly. It acts like an osmotic sponge. Now, if you flush that area with lots of high-volume, fast-moving blood, like in the cortex,
it would wash all the salt away.
instantly, all those carefully established gradients from the loop of Henle would just dissipate. The vasa recta flows slowly, countercurrent to the tubules. This sluggish flow allows it to pick up some water that's reabsorbed, but it doesn't wash out the solutes, the salt and urea that are keeping the medulla concentrated.
Ah, so the low flow preserves the concentrating gradient.
Clever?
Very clever. It's highly specialized circulation matched perfectly to the local function.
Okay, that structure and blood flow makes sense. Now let's get into the actual physiology, how the kidney maintains homeostasis. Right, it boils down to those three main processes we mentioned. Filtration first, getting a large volume of plasma water and small solutes out of the blood. Then reabsorption, selectively pulling back almost everything the body needs from that filtrate. And finally, tubular secretion, actively adding certain waste products or excess ions from the blood directly into the tubular fluid for excretion.
And that filtration rate, the GFR, is just mind-boggling, 125 milliliter per minute.
Yep, which works out to 180 liters of filtrate every single day. Think about that, your entire plasma volume gets filtered something like 60 times a day.
It's incredible, but obviously we don't pee 180 liters.
Not even close. That highlights the efficiency of reabsorption. Only about 19% of the plasma that flows to the kidney actually gets filtered. That's called the filtration fraction.
Okay, GFR divided by renal plasma flow, about a fifth.
Right, but then, of that 180 liters of filtrate produced, the tubules reabsorb over 99% of it back into the blood. We end up excreting maybe 1 to 2 liters a day as urine.
So the kidney is constantly deciding, molecule by molecule almost, what tiny fraction needs to stay out to keep the body's internal environment just right.
That's the essence of it. And the driving force for that initial massive filtration, it all comes down to pressures within the glomerulus.
And this pressure balance, the net filtration pressure, is surprisingly small, isn't it?
That's a huge clinical point. The normal net filtration pressure is only about 10 millimeters of mercury. Tiny margin.
How does that break down?
Okay, you have one main force pushing fluid out of the glomerular capillaries. The glomerular capillary hydrostatic pressure, it's high, usually around 60 millimeter Hg.
Pushing out.
Pushing out. Then you have two forces opposing that, pushing fluid back in or keeping it from leaving. First is the glomerular colloid osmotic pressure. That's the pull from proteins like albumin still in the blood, about 28 millimeter Hg inward.
Okay, proteins pulling water back.
And second is the Bowman's capsule hydrostatic pressure, the pressure of the fluid already filtered into the space around the glomerulus, about 18 millimeter Hg inward.
So 60 pushing out minus 28 plus 18 pushing in.
Leaves you with that net 10 millimeter Hg outward driving force.
10 millimeters of mercury. That feels like walking a tightrope. What happens in the OR if blood pressure drops or if there's a blockage downstream?
It means the kidney is incredibly vulnerable. That tiny 10 millimeter Hg margin is why. If a patient gets hypotensive and that main glomerular pressure drops by just 10 or 15 points,
Filtration stops.
Stops dead. Or, conversely, if you get a sudden obstruction downstream, like a kidney stone blocking the ureter, postrenal injury, the pressure in Bowman's capsule backs up. If that rises by 10 millimeter Hg,
Filtration stops again.
right. It underscores why we as anesthesia providers have to be almost obsessive about maintaining adequate perfusion pressure to the kidneys.
But the kidney isn't just passive, it has defenses, right?
Yeah.
Autoregulation.
It does. It's remarkable. Renal blood flow, RBF, stays incredibly constant, around 1,000 millimene, even if the mean arterial pressure swings wildly between about 50 and 180 millimeter Hg.
Wow, that's a huge range.
It is. Below 50 millimeter HGMAP, though, autoregulation fails and filtration plummets.
How does it do that? Maintain flow despite pressure changes.
Two main ways. First is a simple myogenic mechanism. The smooth muscle in the afferent arteriole just naturally constricts when it gets stretched by higher pressure and relaxes when pressure drops. Basic physics.
Okay, stretch equals constrict.
And second, and maybe more sophisticated, is the tubuloglomerular feedback system. This involves that specialized structure where the distal tubule loops back and touches its own glomerulus, the juxtaglomerular complex or apparatus.
Right, you mentioned that. So how does that local feedback loop work?
It's really elegant. There are special cells in the wall of the distal tubule right there, called the macula densa. Their job is to constantly taste the fluid flowing past. Specifically, they sense the concentration, really the delivery rate, of sodium and chloride ions.
Okay, they're sampling the filtrate.
Exactly.
Yep.
Now, if the GFR drops maybe due to slightly lower blood pressure, less fluid flows past the macula densa, and it senses decreased sodium and chloride delivery.
Interprets that as flow is too slow.
Precisely. And it immediately sends a signal, probably paracrine chemical signals, to the smooth muscle cells of the nearby afferent arteriole, telling them to dilate.
Widen the in-pipe.
Right. That increases blood flow into the glomerulus, raises the glomerular pressure, and brings GFR right back up towards normal. It's a rapid, local fine-tuning mechanism.
Okay, that handles local fluctuations. But what if the problem is bigger, like major blood loss or dehydration, systemic hypotension?
Then the local fix isn't enough, and the body kicks in its major volume and pressure rescue system, the RAAS, the renin-angiotensin-aldosterone system.
The big guns.
Definitely. So if the vacula densa senses that really low Na plus Cl delivery, or if the sympathetic nervous system gets activated by low blood pressure, both of those trigger specialized cells right next to the macula densa, the juxtaglomerular cells, to release an enzyme called renin into the bloodstream.
Step 1, renin release.
Step 1. Renin then finds a protein made by the liver that's always circulating called angiotensinogen, and it clips off a piece, converting it to angiotensin OI.
Okay, angiotensin the first, is that the active one?
Not really.
Yeah.
Angiotensin III is pretty weak. It circulates around, and when it gets to the lungs, it encounters another enzyme embedded in the lung capillaries called angiotensin-converting enzyme, or ACE.
ACE, like the target of ACE inhibitors.
Exactly the one. ACE chops a bit more off angiotensin III and converts it into the really potent form, angiotensin II.
And angiotensin II is the powerhouse. What does it do specifically in the kidney?
It has effects all over the body, but let's focus on the kidney first. Systemically, yes, it's a very powerful vasoconstrictor, clamps down blood vessels everywhere to raise the overall MAP.
Okay, raises systemic pressure.
But its crucial action within the kidney is that it preferentially constricts the efferent arteriole, the outpipe from the glomerulus.
Ah, it squeezes the exit more than the entrance.
Yes. Think about the effect. By increasing the resistance to blood leaving the glomerulus, it effectively traps blood inside the glomerulus, artificially boosting that glomerular capillary pressure, the main driver of filtration.
So even if systemic pressure is low, angiotensin II tries to salvage GFR by cranking up the pressure right inside the filter itself.
That's exactly it. It's the kidney sacrificing downstream blood flow to the peritubular capillaries to prioritize maintaining filtration at all costs. It keeps GFR from collapsing when MAP is low.
That makes so much sense why ACE inhibitors can be risky in certain situations, like dehydration or renal artery stenosis. You're blocking the kidney's main defense mechanism for maintaining GFR.
Absolutely spot on. If a patient is relying on that angiotensin sac-mediated efferent constriction to keep filtering, and you take that away with an ACE inhibitor, their GFR can plummet, lead straight to acute kidney injury, usually prerenal type.
Okay, critical mechanism. So we've made the filtrate, defended the GFR. Now let's follow that filtrate into the tubules where all the sorting happens, starting with the proximal tubule.
Right, the proximal convoluted tubule, or PCT. This segment is the real workhorse for reabsorption. Its main job is pumping sodium ions actively out of the filtrate and back into the body. This is very energy intensive.
Sodium pumps working hard.
Very hard. And because water follows salt osmotically, all that active sodium transport drives massive passive water reabsorption too. About 60–70% of all the filtered sodium in water gets pulled back right here in the PCT.
60 to 70%. What else gets reabsorbed there?
Pretty much all the good stuff.
Yeah.
100% of the filtered glucose, 100% of amino acids, most of the bicarbonate, potassium, phosphate, vitamins, they all get co-transported back with sodium.
So it grabs everything valuable immediately.
Essentially, yes. And it even reclaims small amounts of filtered proteins using a process called penocytosis, like cell drinking.
Okay, bulk reabsorption done. Next stop. The Loop of Henle. Famous for the countercurrent system, right?
Yeah.
All about water conservation.
Exactly. The primary function of the loop of Henle isn't so much about reabsorbing a lot more volume, but about setting up that incredibly steep osmotic gradient in the medulla that we talked about earlier.
Creating the salty sponge.
Creating the salty sponge. It does this through the countercurrent multiplier effect. The descending limb is permeable to water but not salt, so water leaves, concentrating the fluid inside. Then, crucially, the thick ascending limb actively pumps salt, NaCl, out into the medullary interstitium, but this segment is impermeable to water.
So salt leaves, but water is trapped inside the tubule.
Right. This pumps tons of salt into the medulla, making it super concentrated, while the fluid leaving the loop becomes dilute again. This separation of salt and water movement multiplies the gradient.
And the vasa recta helps maintain it.
Yes, the countercurrent exchanger role of the vasa recta. Its slow, looping blood flow picks up the reabsorbed water and some solute, but doesn't wash out that precious medullary gradient. It preserves it.
Okay, gradient established. Where does the final water saving happen? Distal tubule and collecting duct.
Precisely. These final segments are where the fine-tuning occurs, largely under hormonal control. Aldosterone, released in response to angiotensin II or high potassium, acts here. It simulates more sodium reabsorption in exchange for secreting potassium, and also hydrogen ions playing a key role in potassium balance and acid-base control.
Aldosterone. Saves sodium, dumps potassium and acid.
You got it. And then there's ADH and antidiuretic hormone, also called vasopressin. ADH controls the water permeability of the collecting ducts. If the body is dehydrated, ADH levels are high. It inserts water channels, aquaporins, into the collecting duct walls. Now, the tubular fluid flows down through that hyperosmotic medulla.
Water rushes out through the channels into the salty interstitium.
Exactly. Pulled out by osmosis, gets picked up by the vasa recta, and the final urine becomes highly concentrated. If you're overhydrated, ADH levels are low, the collecting duct stays impermeable to water, and you excrete lots of dilute urine.
So ADH is the final tap controlling water loss.
It's the key regulator of final urine concentration and body water balance.
Now, beyond just filtering and balancing fluids, the kidney is an endocrine organ too. What hormones does it release or control?
Yeah, several important ones. First is erythropoietin, or EPO. It's a glycoprotein hormone made by specialized cells in the kidney in response to low oxygen levels.
And it tells the bone marrow
to make more red blood cells. That's why chronic kidney disease inevitably leads to anemia. The failing kidneys just don't produce enough EPO.
Okay, EPO for red cells. We mentioned aldosterone already, triggered by RAAS and potassium.
Right, released by the adrenal gland, but its release is heavily influenced by the kidney via renin-angiotensin, and very strongly by plasma potassium levels. High potassium is actually the most potent stimulus for aldosterone secretion. Then ANG2, then low sodium has a smaller effect.
Interesting. And ADH, made elsewhere but controlled by kidney-related factors.
ADH is actually synthesized up in the hypothalamus in the brain, then stored and released from the posterior pituitary gland, the neurohypophysis. But its release is tightly controlled by osmoreceptors, also in the hypothalamus, that constantly monitor the osmolality, the concentration of the extracellular fluid. High osmolality triggers ADH release to conserve water. Low osmolality suppresses it.
Okay. And there's one more, kind of the anti-RAS hormone.
Ah, yes. Atrial natriuretic factor, or ANF, also called atrial natriuretic peptide, ANP. This one is different. It's released by the muscle cells in the atria of the heart.
Released by the heart. Why?
Is released when the atria gets stretched, which usually means there's too much blood volume fluid overload.
So the heart senses stretch and tells the kidney to dump fluid.
Exactly. ANF is a powerful diuretic and natriuretic, makes you excrete sodium. It directly increases GFR and inhibits sodium reabsorption in the collecting ducts. And crucially, it actively antagonizes the entire RAS system. It suppresses renin release, inhibits aldosterone secretion, and blocks the effects of ADH. It's the body's natural defense against volume expansion. One of the most potent diuretics we know of, actually.
Fascinating. A built-in counterbalance. Okay, that physiology is complex but critical. Let's shift gears now into when things go wrong. Pathophysiology. Starting with acute kidney injury, AKI.
Right. AKI is defined by a rapid decline in kidney function happening within about 48 hours. The diagnostic criteria are pretty specific now, based on things like the KDIGO guidelines. You're looking for either an absolute increase in serum creatinine of 0.3 mg/GL or more,
Okay, small absolute jumps.
or a percentage increase in creatinine of 50% or more from the patient's baseline.
Bigger relative jump.
Or, the one we often see first in the OR, a significant drop in urine output defined as less than 0.5 millirictoliters per kilogram per hour, sustained for over 6 hours, oliguria.
And this isn't rare, is it? About 9% of non-cardiac surgical patients get some degree of AKI.
That's the figure often cited, yes. And the risk factors are things we need to screen for preoperatively. Obviously, pre-existing kidney disease, so a low baseline eGFR, certain high-risk surgeries like major vascular or cardiac,
Makes sense.
but also things like baseline anemia, a higher ASA physical status, and the big one we can influence intraoperatively, the degree and duration of hypotension.
That direct link again. Even mild low blood pressure seems to raise the risk, especially in patients who already have other risk factors.
It absolutely does. Protecting those nephrons means minimizing both how low the pressure goes and for how long it stays low.
We usually categorize AKI based on the cause, right? Pre-renal, intrinsic, post-renal. Let's start with pre-renal AKI.
Pre-renal is the most common type, especially perioperatively. It's purely a perfusion problem. The kidney structure itself is initially okay, but it's just not getting enough blood flow, what we call effective hypoperfusion.
So causes like major bleeding, sepsis causing vasodilation, severe heart failure.
Exactly. Dehydration, burns. Also, certain drugs that interfere with the kidney's ability to cope with low flow, like NSAIDs inhibiting prostaglandins needed for effort dilation, or ACE inhibitors blocking that crucial effort constriction we talked about.
And the prognosis here.
It's generally good if you catch it early and restore perfusion quickly. Give fluids, support blood pressure, stop the offending drug. The kidney usually bounces back.
But if it goes on too long?
Then the prolonged lack of oxygen and nutrients starts to damage the kidney cells themselves, particularly the metabolically active tubule cells. And pre-renal AKI transitions into the next category, intrinsic AKI.
So intrinsic AKI means actual damage to the kidney tissue, the parenchyma.
Yes, this is structural damage. The most common form is acute tubular necrosis, or ATN, where the tubule cells die off.
What causes that direct damage?
It can be ischemia, just prolonged severe hyperperfusion leading to cell death, or it can be toxins. Endogenous toxins, meaning from inside the body, like myoglobin released during muscle breakdown, rhabdomyolysis, or free hemoglobin from massive red cell destruction, hemolysis. Both are toxic to tubules.
Okay. And external toxins.
Exogenous toxins are things we give the patient. Certain antibiotics like aminoglycosides or amphotericin B, some chemotherapy drugs, heavy metals, and a big one we encounter often, radiocontrast dye used for CT scans and angiograms.
Contrast-induced nephropathy?
Right. Intrinsic AKI also includes damage to the glomerulonephritis, or the small blood vessels, vasculitis, but ATN from ischemia or toxins is the most frequent cause we deal with. Prognosis here is much more variable and generally worse than pre-renal.
And the third category, post-renal AKI. This is a plumbing problem.
Exactly. It's obstruction somewhere in the urinary tract after the kidney, anything blocking the flow of urine out.
Like kidney stones in the ureter.
Yeah, nephrolithiasis. Or an enlarged prostate, BPH, clamping down on the urethra, tumors in the pelvis compressing the ureters, retroperitoneal fibrosis, even just a blocked Foley catheter can cause it if not recognized.
And the mechanism is that back pressure.
Yes, the urine backs up, increasing pressure in the ureters, the renal pelvis, and eventually inside Bowman's capsule. When that capsular pressure gets high enough to equal the glomerular filtration pressure.
It cancels out the net filtration pressure, stops filtration.
Correct. The good news, similar to pre-renal, is that if you relieve the obstruction, quickly remove the stone, place a stent, unblock the catheter, the pressure drops, filtration resumes, and the prognosis for recovery is usually very good.
Okay. Now, when we talk about how severe the AKI is, we use staging systems. You mentioned KDIGO, but there were others like RIFLE and KDIGO before that. How did these change things?
It was a big shift. Before these formal systems, AKI was often diagnosed late, when things were already quite bad. People talked about oliguric renal failure, less than 400 millimole urine per day, or non-oliguric or anuric, no, urine. It was more descriptive after the fact.
More black and white.
Right. The RIFLE criteria, risk, injury, failure, loss, end stage, then AKIN, Acute Kidney Injury Network, and now the widely adopted KDIGO, kidney disease, improving global outcomes, guidelines. They all use standardized tiered changes in serum creatinine and urine output.
So they create defined stages.
Yes. They allow us to identify patients much earlier, often at the risk or stage 1 level, based on smaller changes. This hopefully prompts earlier intervention, better fluid management, avoiding nephrotoxins, optimizing hemodynamics before the injury progresses to full-blown failure or worse. It pushed the field toward prevention and early management rather than just dealing with established failure.
Makes sense. Proactive versus reactive. Now, let's shift from acute injury to the slower progressive decline. Chronic kidney disease, or CKD.
CKD is defined differently. It's not a rapid event, but a slow, progressive, and generally irreversible loss of kidney function. The standard definition is evidence of kidney damage, like proteinuria, or a glomerular filtration rate, GFR, less than 60 milliliters per minute per 1.73 meters in body surface area that persists for 3 months or longer.
GFR 60 for 3 months.
That's the key threshold. And CKD is also staged from stage 1, where GFR might actually be normal or even high, but there's evidence of kidney damage, all the way to stage 5.
And stage 5 is?
Stage 5 CKD is end-stage renal disease, or ESRD. That's defined as a GFR below 15 millimin, 1.73 meters in the blood. At this point, patients typically require renal replacement therapy, dialysis, or transplantation to survive.
And this is when we start talking about uremia.
Yes. Uremia, literally urine in the blood, is the clinical syndrome that results when kidney function is severely impaired, usually when about 90–95% of nephron function is lost, corresponding roughly to stage 5. All those waste products, excess electrolytes, and fluid that the kidneys normally excrete start to build up and poison virtually every organ system in the body.
The systemic effects are profound. We really need to understand these when planning anesthesia for a CKD patient. Let's walk through the major systems, starting with cardiovascular.
Cardiovascular complications are probably the leading cause of death in CKD patients. Hypertension is almost universal, seen in maybe 90% of patients, and it's often volume dependent because they can't excrete salt and water properly.
So fluid overload drives the high blood pressure.
Very often, yes. This also leads to a high incidence of congestive heart failure, CHF. They also have accelerated atherosclerosis, meaning a much higher risk of coronary artery disease, heart attacks, strokes, peripheral vascular disease.
And something specific we worry about perioperatively, pericarditis.
Yes, uremic pericarditis,
Yeah.
inflammation of the sac around the heart. It occurs in a significant number of patients with severe uremia, maybe up to 50%. It's often a fibrous type. And the big danger is that it can lead to a large pericardial effusion, sometimes hemorrhagic.
Which can lead to
Cardiac tamponade. Acute compression of the heart, which is a life-threatening emergency. So careful fluid management and being vigilant for signs of tamponade are critical.
Okay, huge cardiovascular risks. What about hematologic issues, blood problems?
2 main things here. First, as mentioned with EPO, essentially all patients with significant CKD develop anemia. It's typically normochromic, normocytic, meaning the red cells look normal. There just aren't enough of them because of that decreased erythropoietin production.
So expect them to have a low hematocrit.
Absolutely. The second issue is coagulopathy. Uremia causes platelet dysfunction. The platelet count might be normal, but they don't stick together or aggregate properly.
So they bleed easily.
They have a definite tendency towards increased bleeding, especially mucosal bleeding or oozing from surgical sites, even if their standard coagulation tests like PT and PTT are normal.
Does dialysis help with that?
Dialysis does help improve platelet function somewhat, but it often doesn't completely normalize it. If bleeding is a major concern for a planned surgery, sometimes agents like desmopressin, DDAVP, are given preoperatively to temporarily boost platelet activity.
Good to know. Finally, the complex metabolic derangements.
Oh yeah, this is where it gets really complicated. First, they almost always have metabolic acidosis. The failing kidneys can't excrete the daily load of acid produced by metabolism, primarily because the distal tubules lose their ability to secrete hydrogen ions.
Can't get rid of acid.
Right. Second, hyperkalemia, high potassium levels. Again, the failing distal nephrons can't adequately secrete potassium. This is often worsened by the acidosis, which causes potassium to shift out of cells into the bloodstream. Hyperkalemia is incredibly dangerous because it can cause fatal cardiac arrhythmias.
Always check the potassium level pre-op in CKD patients.
Always, always. And then there's the whole issue with calcium phosphate in bone disease. The kidneys normally play a crucial role in activating vitamin D.
To its active form.
Yes. Without active vitamin D, you can't absorb calcium properly from the gut. So, CKD patients develop hypocalcemia, low calcium. The body tries to compensate by increasing parathyroid hormone, PTH secretion, which pulls calcium out of the bones.
Weakening the bones.
Exactly. Plus, the kidneys also fail to excrete phosphate, leading to hyperphosphatemia, which further lowers calcium and worsens the bone disease. This whole complex is called renal osteodystrophy. These patients have fragile bones, prone to fractures just from positioning sometimes.
Wow. Acidosis, hyperkalemia, hypocalcemia, anemia, coagulopathy, hypertension, heart failure risk. It really affects everything.
It truly is a systemic disease when it reaches the later stages.
Okay, so managing these patients perioperatively is clearly about minimizing further harm and navigating all these existing problems. Let's talk specifically about anesthetic drugs and strategies. What about our general anesthetics? Do they impact renal function directly?
The short answer is yes. Pretty much all general anesthetics can alter renal function, at least temporarily. A key finding is that even if you keep the patient's MAP stable, say well within the normal range like 80 or 90,
Renal blood flow can still drop.
it often does. Decreases of 30–40% in RBF have been reported, even with normal MAP. This strongly suggests that general anesthesia somehow impairs or blunts the kidney's own autoregulation mechanisms that we discussed earlier.
So the kidney becomes more pressure dependent under anesthesia.
That seems to be the case. The volatile agents, isoflurane, desflurane, sevoflurane, also tend to cause a mild to moderate increase in renal vascular resistance, which might be a compensatory response, but it contributes to that reduced flow.
Now, historically, there was a big concern about direct nephrotoxicity from anesthetics, right? Methoxyflurane.
Ah, yes, methoxyflurane. That's the classic cautionary tale. It was significantly metabolized, releasing large amounts of inorganic fluoride ions, like 60 to 90 micromoles per liter in the blood.
And fluoride is bad for the kidneys.
At those concentrations, yes. Fluoride ions were found to directly damage the renal tubules, especially the proximal tubules and the loop of Henle. They also interfered with ADH action in the collecting ducts.
What did that cause clinically?
It caused a specific type of renal failure called high-output renal failure, or vasopressin-resistant polyuria. Patients couldn't concentrate their urine at all, peed out huge volumes, got dehydrated, and developed azotemia despite the high urine output. It essentially poisoned the concentrating mechanism.
Okay, so methoxyflurane was definitely out. What about our modern agents? Sevoflurane gets metabolized a bit, maybe 5–8%, and does release some fluoride ions. Is that a concern?
That was a big question when Sevo first came out. Peak fluoride levels after prolonged sevoflurane anesthesia can sometimes reach levels similar to those seen with methoxyflurane, maybe around 50 wardles.
So why isn't it toxic?
Well, decades of use now show it lacks that nephrotoxicity. The leading theory is that it's not just the peak serum fluoride level that matters, but the concentration generated within the kidney cell itself. It seems sevoflurane undergoes much less intrarenal metabolism compared to methoxyflurane. So even if systemic levels get a bit high, the concentration right at the site of potential damage in the tubules stays much lower, below the toxic threshold.
Makes sense. But there was another worry with sevoflurane compound A.
Right, compound A is a vinyl ether degradation product that forms when sevoflurane chemically reacts with the strong alkali bases, specifically sodium hydroxide and potassium hydroxide, found in traditional CO2 absorbents used in anesthesia machines.
And compound A was potentially toxic to the kidneys.
Animal studies, mainly in rats, showed it could cause renal tubular injury, particularly with low fresh gas flows, FGF, where it could accumulate in the breathing circuit. This raised concerns about using Sevo with low-flow techniques aimed at conserving agent.
So what was the guidance?
The FDA issued recommendations. Basically, when using sevoflurane with traditional absorbents, maintain a minimum fresh gas flow of at least 1 liter per minute. And if flows are between 1 and 2 RN, limit the exposure to a maximum of 2 air mass CR.
Okay. Has that changed?
Yes, largely because the CO2 absorbents themselves have changed. Most modern absorbents like Amzor Plus or litholine don't contain those strong bases anymore. They use calcium hydroxide or lithium hydroxide.
And they don't produce compound A.
They produce negligible or undetectable amounts. So with these newer absorbents, the concern about compound A toxicity, even with very low flows, has essentially disappeared. Sevoflurane is now considered very safe from a renal perspective.
Good to know. Okay, let's move to managing pain. Opioids in patients with renal failure. This sounds tricky due to metabolites building up.
Extremely tricky.
Yeah.
This is where drug choice becomes absolutely critical because normal doses can become dangerous overdoses if active metabolites accumulate because they can't be cleared by the failing kidneys.
So which one should we absolutely avoid?
Top of the avoid list is meperidine, or Demerol. Its main metabolite is normeperidine.
And normeperidine is bad because...
A potent CNS stimulant, it causes tremors, muscle twitches, myoclonus, and can easily progress to full-blown seizures. And the real kicker is that normeperidine is poorly water-soluble and highly protein-bound.
Meaning?
meaning it is not effectively removed by hemodialysis. So if you give repeated doses of meperidine to a patient with kidney failure, normeperidine just builds up and up in their system, leading to neurotoxicity. It's contraindicated. Just don't use it.
Okay, meperidine is out. What about the workhorse, morphine?
Morphine needs extreme caution. Morphine itself is cleared okay, but its major active metabolite is morphine 6-glucuronide, or M6G.
M6G, is that active?
Oh yes, M6G is actually more potent and longer lasting as an analgesic and respiratory depressant than morphine itself.
Oh, wow.
And like normeperidine, M6G accumulates significantly in renal failure because it relies on renal excretion. And again, it's not well removed by dialysis.
So the risk is prolonged, unpredictable respiratory depression hours after the last dose.
Exactly. Patients can seem fine initially, then develop severe respiratory failure later as M6G levels climb. Hydromorphone, diluted, also has an active metabolite, H3G, that accumulates, though maybe less profoundly than M6G. Caution is still needed.
So if morphine and hydromorphone are risky and meperidine is out, what are the safer opioid choices?
Generally, the synthetic opioids like fentanyl and sufentanil are considered much safer. They're primarily metabolized by the liver into inactive metabolites, so their clearance isn't significantly affected by renal failure.
Okay, fentanyl, sufentanil seem better. Any others?
Methadone also relies mainly on hepatic metabolism and has inactive metabolites, making it a reasonable option, especially for chronic pain management. And transdermal buprenorphine is another possibility.
And the unique one, remifentanil.
Remifentanil is often considered the ideal choice for intraoperative use in renal failure. Why? Because it's broken down incredibly rapidly by non-specific esterase enzymes right in the blood plasma and tissues.
So its clearance is totally independent of kidney or liver function?
Pretty much. Makes it highly predictable, ultra-short-acting, and accumulation isn't really an issue. However, it's worth noting that some studies have shown a significant reduction in remifentanil clearance, specifically in ESRD patients, so maybe not completely independent, but still generally the safest for continuous infusion during surgery.
Good summary. Now, neuromuscular blockers, muscle relaxants. The big concern here is potassium, right? Hyperkalemia.
That's the primary danger, especially with succinylcholine. Succinylcholine reliably causes potassium to leak out of muscle cells, raising the serum K+ level by about 0.5 mQOL on average in normal patients.
And in a patient who already has high potassium from CKD?
That extra 0.5 can be enough to push them over the edge into dangerous hyperkalemia levels above 5.5 or 6.0 mQOL. This can cause ECG changes like PT waves, wide QRS complexes, and potentially lead to ventricular fibrillation and cardiac arrest.
So succinylcholine is generally contraindicated if the pre-potassium is already elevated, say above 5.5.
Absolutely. It's playing with fire. You need a recent potassium level before using it in any patient with significant renal impairment.
Okay, so if we can't use Suturex, what are the preferred non-depolarizing muscle relaxants?
The clear winners here are etracurium and its isomer, cisatracurium. Their elimination pathway is unique.
Hoffman elimination.
Exactly. They spontaneously break down in the plasma at physiological temperature and pH via a non-enzymatic chemical process called Hoffman elimination. They also undergo some hydrolysis by non-specific esterases. Crucially, neither process depends on kidney or liver function.
So their duration of action is totally unchanged in renal failure.
Correct. That makes them the drugs of choice when you need predictable paralysis duration.
What about the common aminosteroids like vecuronium and rocuronium?
They can be used, but with caution and awareness. Vecuronium relies on the kidneys for about 30% of its elimination. Rocuronium is mainly biliary, but still up to a third can be excreted renally.
Meaning their duration will be prolonged.
Significantly prolonged, especially with repeated doses or infusions. You absolutely need reliable neuromuscular monitoring if you use them, and expect recovery to take much longer than usual.
And reversal. Can we use Sugammadex for rocuronium or vecuronium in these patients?
Yes, Sugammadex is effective at reversing rocuronium and vecuronium blockade, even in patients with severe renal impairment. It works by encapsulating the drug molecule.
But what happens to the Sugammadex rock complex?
That complex is normally excreted unchanged by the kidneys. So in severe renal failure, the complex hangs around in the circulation for a much longer time. Exposure is prolonged.
Is that harmful?
Current data, including from kidney transplant patients, suggests it's safe and doesn't cause nephrotoxicity or recurrence of blockade. But it's something to be aware of. Interestingly, high-flux hemodialysis can effectively remove the Sugammadex drug complex if needed for some reason.
Okay, good to know. Let's wrap this section with fluid strategy. What's the overarching goal preoperatively?
The absolute goal is to get the patient euvolemic before they even come to the OR. You want to avoid both dehydration, which risks pre-renal AKI, and fluid overload, which worsens hypertension and CHF.
So optimize volume status beforehand?
Yes. Adequate hydration before induction is crucial to minimize the release of ADH and activation of the RAAS system that occur with hypovolemia and surgical stress.
And if the patient is on dialysis, timing matters.
Very much so. Ideally, dialysis should be done the day before surgery, about 24 hours prior. This gives time for fluid shifts to equilibrate and electrolytes, especially potassium, to stabilize. Dialyzing right before surgery can leave them volume depleted or with unstable electrolytes.
And always check that potassium level just before surgery.
Mandatory. If the K+ is significantly elevated, say above 6.0 MEQL, despite recent dialysis, surgery might need to be postponed for emergency hemodialysis to bring it down.
Okay. Now, intraoperatively, if we see the urine output drop oliguria, what's the first move?
Assume it's pre-renal until proven otherwise. That means the immediate response should be a fluid challenge.
Oh my.
Typically 500 to 1,000 milliliters of crystalloid for most adults. Maybe a smaller bolus like 250 milliliters if you know they have poor cardiac function and you're worried about overload, but assess the volume status and give fluid first.
And what should we absolutely not do first?
Do not reach for a diuretic like furosemide Lasix just to make urine. This is a critical point.
Why not?
Because if the oliguria is due to hypovolemia, giving a diuretic will only worsen the volume depletion, further reduce renal perfusion, and potentially convert a reversible pre-renal state into established intrinsic AKI, ATN. It makes things worse.
So diuretics are not for preventing AKI or treating hypovolemic oliguria. When do we use them?
Diuretics like furosemide are indicated for treating documented fluid overload, like pulmonary edema, or sometimes to help manage severe hyperkalemia by promoting potassium excretion, but never as a first-line response to low urine output without confirming volume status first. Optimize hemodynamics, give fluid if needed. That's the primary intervention.
Got it. Fluid first, diuretics only for overload. Crucial distinction. Okay, let's move into some specific urologic procedures that have unique anesthetic considerations, starting with ESWL extracorporeal shock wave lithotripsy, breaking up kidney stones from the outside.
Right. ESWL is used for smaller stones, usually less than 10 or 20 millimeters. It uses focused, high-energy sound waves generated outside the body.
How do the shock waves break the stone?
Two main ways. There's some direct mechanical stress from the wave hitting the stone, where there's an abrupt change in density. But probably more important is cavitation. The negative pressure phase of the shock wave creates tiny bubbles in the fluid around the stone. When these bubbles violently collapse, they generate powerful microjets and secondary shock waves that chip away the stone.
Sounds painful. What's needed anesthetically?
Patients definitely cannot tolerate ESWL awake. The shock waves cause significant pain in the flank area as they pass through tissue, and the patient needs to lie perfectly still for the waves to stay focused on the stone. So it requires either deep sedation or, more commonly, general anesthesia for akinesia, immobility, and analgesia.
Is there a specific safety concern during ESWL?
Yes, a major one involving the heart. The high-energy shock waves can potentially trigger cardiac arrhythmias if they happen to hit the heart during its vulnerable repolarization period, the T wave on the ECG.
So you need to time the shocks.
Absolutely. The lithotripter must be synchronized with the patient's ECG. It's set up to only fire the shock wave during the R wave, which corresponds to ventricular depolarization, a relatively safe period electrically. Firing randomly risks inducing things like premature ventricular complexes, PVCs, or even runs of supraventricular tachycardia. ECG gating is mandatory.
Okay, critical safety point for ESWL. Now, let's discuss a classic complication we always have in the back of our minds during prostate surgery, TURP syndrome, transurethral resection of the prostate.
Ah, yes, TURP syndrome. While improvements in technique and equipment have made it less common than it used to be, it's still a risk, maybe seen in 0.8 to 1.4% of TURP procedures.
It can be serious.
Potentially fatal if severe. Mortality rates up to 25% have been reported for severe cases, although that's likely lower now with earlier recognition.
What actually causes it?
It's caused by the absorption of large volumes of the hypotonic irrigating fluid that the surgeon uses to distend the bladder and wash away blood and tissue during the resection.
How much fluid are we talking about?
It can be substantial. The venous sinuses and the prostate are often cut open during resection, providing direct access for the irrigant into the circulation. Absorption rates of 10 to 30 millibars per minute have been estimated. Over a 1 or 2 hour procedure, a patient could potentially absorb 6, 8, even 10 liters of this fluid.
Wow, and that leads to two main problems, right? Volume overload and low sodium.
Exactly, it's a double whammy. First, you get acute hypervolemia or volume overload from all that extra fluid hitting the circulation quickly. This can cause acute hypertension, reflex bradycardia from the hypertension, shortness of breath, and even frank pulmonary edema, especially in elderly patients or those with poor heart function.
Okay, volume overload. And the second part.
The second, and often more dangerous part, is acute dilutional hyponatremia. Because the irrigating fluid is hypotonic, has less salt than blood, absorbing large amounts of it dilutes the sodium in the patient's bloodstream.
How much can the sodium drop?
It can drop significantly. As a rough rule of thumb, absorbing just 1 liter of hypotonic irrigant can lower the serum sodium by about 5 to 8 milli-QL. So absorbing several liters can lead to profound hyponatremia very quickly.
And that's when we see the really dangerous signs, especially neurological.
Yes. The symptoms are primarily related to cerebral edema caused by water shifting into brain cells due to the low plasma osmolality. When the serum sodium drops below about 120 milli-QL, patients start to become symptomatic.
What kind of symptoms?
Early signs might be restlessness, agitation, confusion, nausea, headache. As it gets worse, you can see twitching, lethargy, seizures, coma, and eventually respiratory arrest. Below 115 milli-QL is considered critical.
And ECG changes too.
Yes, severe hyponatremia can cause ECG changes like a widened QRS complex, ST segment elevation, or arrhythmias.
This really highlights why regional anesthesia, like a spinal, is often preferred for TURPs, doesn't it?
It absolutely does. If the patient is awake under spinal anesthesia, needs to be adequate, maybe T10 level, they can report those early neurological symptoms, confusion, restlessness, visual changes much sooner than an anesthesiologist might notice subtle signs in a patient under general anesthesia. It allows for earlier detection and intervention.
Makes sense. Now, about the irrigating fluids themselves, we can't use normal saline because it conducts electricity, right?
Correct. For monopolar TURP, the irrigant has to be non-conductive or poorly conductive. Distilled water used to be used, but that's extremely dangerous because it's so hypotonic it causes massive hemolysis, red blood cell rupture, if absorbed.
So what do they use now?
The most common ones are solutions of glycine, usually 1.2% or 1.5%, or a mixture called Cytal, sorbitol plus mannitol. These are close to isotonic overall, but they contain no electrolytes, so they're still effectively hypotonic regarding sodium concentration if absorbed systemically.
And glycine itself can cause problems if absorbed? Glycine toxicity?
Yes, glycine is not inert. Firstly, excessive glycine in the bloodstream can cause transient blindness or visual disturbances due to effects on retinal neurotransmission. Glycine is an inhibitory neurotransmitter.
Temporary blindness, wow.
And secondly, and perhaps more seriously, the liver metabolizes absorbed glycine into ammonia. If large amounts are absorbed, this can lead to hyperammonemia, causing significant CNS depression, encephalopathy, confusion, and potentiating seizures. So glycine adds its own layer of potential toxicity on top of the fluid overload and hyponatremia.
Okay, so TRRK syndrome is serious. How do we prevent it, or at least minimize the risk?
Prevention is key. As we said, considering regional anesthesia helps with early detection. The surgeon plays a big role by trying to limit the resection time, ideally keeping it under 1 hour, as absorption is time-dependent.
Shorter surgery, less absorption.
Right. Also, carefully controlling the height of the irrigating fluid bag above the patient is crucial. Keeping the bag height relatively low, ideally less than 60 centimeters above the prostate level, reduces the hydrostatic pressure that drives fluid into those open venous sinuses.
Lower pressure, less absorption. Makes sense.
Using bipolar TURP technology, which can use saline irrigation, also significantly reduces the risk of TURP syndrome compared to traditional monopolar resection.
Okay, prevention is ideal. But if TURP syndrome does develop and we suspect significant fluid absorption and hyponatremia, what's the treatment?
First step is always stop the surgery immediately, or at least halt the irrigation, alert the surgeon, confirm the diagnosis.
Okay, stop the input, then what?
Manage the ABC's airway, breathing, circulation, oxygen, support ventilation if needed, treat the volume overload aggressively, usually with furosemide, Lasix, to promote rapid diuresis of the excess free water.
Get rid of the extra fluid. What about the low sodium?
Treating the hyponatremia is critical, but must be done carefully, especially if it's severe, sodium below 120, and symptomatic confusion, seizures. The treatment is hypertonic saline, usually 3% or sometimes 5% ACL solution.
But you have to give it slowly, right? Because of that risk of brain damage.
Exactly. This is paramount. If you correct severe hyponatremia too quickly, you can cause a devastating neurological condition called osmotic demyelination syndrome, ODS, previously known as central pontine myelinolysis.
What happens in ODS?
Rapid shifts in osmolality damage the myelin sheath around nerve fibers, particularly in the pons area of the brainstem. This can lead to permanent neurological deficits like paralysis, quadriparesis, difficulty swallowing, inability to speak, mutism, and locked-in syndrome. It's catastrophic.
So how slow is slow enough for correction?
The generally accepted rule is to correct the serum sodium no faster than 0.5 mQL per hour. The goal is usually to raise the sodium level just enough to stop the acute neurological symptoms, like seizures, often aiming for a level around 120 mQL initially, and then correct much more slowly after that. Never aim for rapid normalization. Slow and steady wins the race here.
Okay, 0.5 mQ per hour max. Got it. Very important point. Let's finish with minimally invasive surgery, laparoscopy, and robotics, which are increasingly common in urology. These have their own set of challenges related to the pneumoperitoneum and positioning.
These certainly do. Laparoscopic and robotic urologic procedures rely on insufflating the abdomen with carbon dioxide, CO2, to create space, the pneumoperitoneum. And they often require the patient to be in a very steep Trendelenburg position, head down tilt, for surgical exposure, especially for pelvic procedures like prostatectomy.
What are the main complications from the CO2 pneumoperitoneum itself?
Two big ones. First, the patient inevitably absorbs some of that CO2 across the peritoneal membrane into the bloodstream. This leads to hypercarbia, high blood CO2 levels, and subsequent respiratory acidosis.
Which means we have to.
We have to use controlled mechanical ventilation and actively increase the minute ventilation, breathe faster or deeper for the patient, to compensate and blow off that extra CO2, keeping the acid-base balance reasonable.
Okay. Manage ventilation for acidosis. What's the second issue?
The second is the increased intra-abdominal pressure, IAP itself. Even pressures commonly used, 12-15 millimeter Hg, compress the abdominal organs and blood vessels, including the renal veins and potentially the kidneys themselves.
How does that affect the kidneys?
Increased IAP is known to activate the sympathetic nervous system and the RAAS system, leading to renal cortical vasoconstriction. It directly reduces renal blood flow, RBF, and can decrease GFR. So the pneumoperitoneum itself poses a risk of contributing to AKI, especially if prolonged or in susceptible patients.
Okay, CO2 causes acidosis, pressure reduces kidney blood flow. What about the steep Trendelenburg position? What risks does that add?
Steep Trendelenburg adds a whole host of physiological challenges. The head-down tilt dramatically increases venous return to the heart initially, but more importantly, it significantly raises central venous pressure, CVP. It also increases intracranial pressure, ICP, and intraocular pressure, IOP.
Higher pressure in the head and eyes. Concerns there.
Yes. Potential for worsening cerebral edema in patients at risk, and concerns about optic nerve injury or worsening glaucoma due to the high IOP, especially during very long procedures.
And effects on breathing and the airway.
The increased abdominal pressure pushes the diaphragm up into the chest, reducing lung volumes, functional residual capacity. And the combination of the head-down position and fluid shifts often leads to significant facial and airway edema over the course of a long robotic case.
Making extubation potentially difficult.
Definitely. There's a real risk of post-extubation airway obstruction if the edema is severe. Careful assessment before pulling the tube is essential, sometimes requiring a cuff leak test.
And fluid management during these robotic cases sounds like another tightrope walk.
It really is. Surgeons often request very restrictive fluid management, especially during critical parts like dissection around the bladder or anastomosis during a prostatectomy.
Why so restrictive?
Because excessive intravenous crystallate fluid can lead to tissue edema, which can obscure surgical planes, make dissection harder, and potentially compromise the quality of the anastomosis, the reconnection of tissues. They might ask for less than, say, 800 milliliter total during that critical phase.
But we need to maintain kidney perfusion.
Exactly. So we're caught between the surgeon's need for a dry field and minimal tissue swelling, and the patient's physiological need for adequate volume to maintain cardiac output and renal perfusion, especially given the adverse effects of the pneumoperitoneum and positioning.
Constant communication needed.
Absolutely crucial. You need to carefully balance minimal crystalloid during dissection, using vasopressors if needed to support pressure, and then replacing fluid deficits more cautiously afterwards. Maybe aiming for a total intraoperative volume around 2,000 milliliter for a long case, but it requires constant vigilance and discussion with the surgical team.
A very challenging anesthetic balancing act indeed.
It truly is. Managing these cases well requires a deep understanding of all these interacting physiological stresses.
Okay, let's try to synthesize this. What are the absolute core lessons for someone aiming for that elite level of understanding in perioperative renal management?
I think it boils down to recognizing the kidney's simultaneous resilience and fragility. It has amazing compensatory mechanisms like autoregulation and RAAS, but it operates on that razor-thin 10 mm Hg filtration pressure margin. So hypoperfusion, even if seemingly mild or brief, is the enemy. Mastery comes from, I'd say, 3 pillars of precision. First, meticulous preoperative assessment to identify those at risk for AKI or who have underlying CKD. Know their baseline function and comorbidities.
Know the starting point.
Second, absolutely judicious drug selection, especially with opioids and muscle relaxants. Understanding metabolite accumulation, avoiding things like normoperidine and M6G is non-negotiable. Choosing drugs like cisatracurium or remifentanil when appropriate.
Precision pharmacology.
And third, a relentless commitment to maintaining euvolemia and adequate renal perfusion pressure throughout the perioperative period, avoiding both dehydration and overload, using fluids wisely, and interpreting oliguria correctly fluid first, not diuretics.
It really drives home that managing these patients isn't about fixing kidney failure after it happens, but about actively supporting the system, respecting its narrow safety margins, and preventing the injury in the first place. It's less drug delivery, more managing internal equilibrium.
You've nailed it. It's a high-wire act of physiological support.
So let's end with that provocative thought, building on what we learned about the kidney's own defenses.
Right. We talked about atrial natriuretic factor, ANF, that hormone the heart releases in volume overload, which is this incredibly potent diuretic, and RAAS blocker.
The kidney's natural off switch for salt and water retention.
Exactly. So the thought is, given how powerful ANF is, could we potentially harness that pathway more? Could synthetic ANF's analogs, or drugs that mimic its effects, be used more strategically, perhaps outside of surgery, to manage situations of acute fluid overload, like in heart failure exacerbations?
As an alternative or adjunct to just loop diuretics, leveraging the body's own counter-regulatory system.
Precisely. Could it offer a more physiological way to promote diuresis while actively suppressing the detrimental RAAS activation that often accompanies diuresis? It's an area where understanding the kidney's endogenous mechanisms might point towards future therapeutic strategies. Something to think about.
Definitely something to mull over, using the body's own tools. A great place to leave it.